there, and welcome to the APAPP podcast. I'm Haley Hoy. I am the chair of the Pulmonary Transplant Committee, and this is our episode, and we are welcoming Sara Brenza, who is a nurse practitioner at Norton Thoracic Institute in Phoenix, and also Elizabeth Olsen, who is a nurse practitioner at Mayo in Rochester. She also is the supervisor for the transplant NPPA practice. So welcome, both of you.
Thank you.
Thank you.
So I'd like to start with just tell us a little bit. We'll start with Sara. Tell us about your experience in lung transplantation. The majority of our listeners are pulmonary APPs. Tell us how you started in lung transplantation and your journey to becoming an APP in lung transplant.
Sure. This is my first job post NP school. I have a background in ICU care, and I've always kind of enjoyed care, pulmonary. And honestly, this job just kind of found me at the right place, right time. I have been here at the Norton Thoracic Institute at St. Joseph Hospital in Phoenix since about 2017, early 2018.
Wonderful. Wonderful. Elizabeth, tell us about your journey.
So this also was my first job as a nurse practitioner post NP school. I've been at Mayo Clinic for my whole nursing and NP career. I did a few years in CV surgery, which our transplant hospital team is kind of housed under CV surgery. So I worked about 7 to 8 years as a nurse in CV surgery, and then I worked in heart rhythm services, and then in the emergency department as a nurse, and then went to NP school. But I was really excited to get into the kind of specifically transplant piece of things because my father is actually a transplant patient. And so we've been blessed with an additional 22 years with him because of a family's generous gift of life to my father. So I always had a transplant near and dear to my heart.
Wonderful. And what I'm hearing you both say is addictive. So once you that transplant pool, you never leave. That's been my experience as well. So I think a lot of our listeners are interested in transplant. They may see it from time to time, but would just like to know a little bit more about it. So Sara, tell us a little bit about patient referral. How do you know when to refer a patient and what is the process for a lung transplant referral?
Yeah, it's a great question because transplant is its own specialty within the pulmonary specialty, right? So one thing to always remember is guidelines, right? Guidelines, for care, for, treatment. So for lung transplant, guidelines for when to refer are really outlined in the International Heart and Lung Transplant Society guidelines. The way to find them is really simple. Go to your favorite search engine, type in INCHLT guideline, and us will pull up the document for when to refer patients, when patients are actually listed. It has a lot of great information within that document itself. Now, when it comes to like the individual lung disease states, the most common lung disease states that do get transplanted are COPD, pulmonary fibrosis, pulmonary hypertension. And they each have their own specific guidelines for when you refer patients. But just to kind of, go over, some of the general information, for COPD, for example, when you refer patients, their SPV1 is less than 25%. They have a BOLD score of 5 or higher, and they show hypercapnia, like a CO2 above 50 on an arterial blood gas. For IPS, the guidelines say refer a patient when the SBC is less than 80% or the DLCO is less than 40%. And for pulmonary arterial hypertension, the guidelines also show to, a revealed score of 8, as well as if they have RV dysfunction off of an echocardiogram, as well as if they're needing and starting IV prostacyclin therapy.
Wonderful. That's a lot of really good information. Elizabeth, as the community providers in pulmonary, what can we tell our patients to expect during and after the procedure?
Sure. So I think when a patient first gets called to come in for a lung transplant, the actual lung transplant procedure is about 6 to 8 hours. But we typically tell their family to expect them to be gone for 10 to 12 hours before they'll see them again. In an ideal, perfect lung transplant situation, we would expect the patient to be in the ICU for 1 to 2 days and then discharge within 7 to 10 days post transplant. You can tell your patients to expect to take a lot of medications. We will give them immunosuppressants. Usually they're on 3 different immunosuppressants. antifungals, antivirals, and antibacterials. They may also need to take some magnesium post-transplant, a proton pump inhibitor. We often recommend multivitamins, calcium, vitamin D, etc. If you're talking to your patients about what to expect after transplant, I also think it's really important to set realistic expectations and to tell your patients that having a transplant is hard. It's a big procedure, a big surgery. And due to their chronic illness prior to transplant, they're already deconditioned and weak. And then they have a big surgery. They get high doses of steroids. We give them induction therapy to sort of squash their immune system. And then comes the hard work where they have to rehabilitate. So, transplant is a lot of physical rehabilitation to rebuild the muscle and get stronger. And the muscles in their chest have been breathing differently with non compliant lungs. And those muscles don't change right away. It takes a little bit of time to retrain both the muscles and the brain after transplant. So, setting realistic expectations for your patient can really set them up for success. Post lung transplant is a lot of work. Be prepared to work hard. Be prepared for it to feel hard. A lung transplant is not an immediate fix. Sometimes people think that they're going to get a lung transplant and it's going to get magically better. Everything's going to be great as soon as they have the transplant. But it's going to take some time and a lot of work, and then things will get better.
Wonderful. Yeah, those comorbidities they come in with don't magically go away. That's that's been my experience. So as usual, I'm a little bit ahead of myself. So these patients sometimes wait months to years on the transplant list. So what can we educate our patients about for what they can anticipate related to that 3 to 4 day evaluation at a transplant center and what happens while they're on the wait list, Sarah?
When I tell patients, for when they are on the wait list, you know, I wouldn't necessarily say it's a countdown to being transplanted. Okay. There's many factors that go into finding the right match donor. I often will tell patients it's like finding a mirror image of yourself out there, that has about the same height, same size lung, blood type, tissue, antibodies. There's a lot of different things that go into making sure it's the right donor. Of course, we want you to be successful as a recipient. So there's a lot of things that we have to be, mindful for finding the right donor. Now, every, transplant center, they have, different wait time. Um, at our institution, it's about, a 2 week period, but there's also patients in the hospital waiting for transplant as well out of the hospital. So there is no exact, countdown time frame, maybe an estimation, but again, there's a lot of factors that go into it. Now, when they're on the list, it's important to make sure that they're still healthy on the list, meaning that, we don't see any of the end or organ dysfunction. We are, maintaining proper lab work, making sure there's no infections going on, updating pulmonary function testing, minute walk testing, all that information that we do ensure to to ensure that the patient snapshot of their testing is reflective of where they currently are in their lung disease. Because as we all know, these are chronic lung diseases. They may change over time. They may change quickly. So while you're on the wait list, it's very important that we make sure that you are, of course, being taken care of and treated, but then also that your data is reflective of where you were on the list.
Perfect. No, I think those are great points. And Elizabeth, as community providers, what can we do as APPs out there to support them while they're listed?
Yeah, that's a great question. While the patient is listed and waiting for transplant, we recommend that they stay up to date on their vaccinations, especially for like heading into flu season or something like that. Make sure you're getting those. Notify the transplant center if they have any infections or any illnesses or a significant new wound. Remind them to keep up to date on their dental appointments and regular health maintenance, not to put those things off while they're waiting. Additionally, there's quite a bit of research surrounding lung transplant prehabilitation or prehab. And prehab involves a series of interventions that include like exercise and education, and it's aimed at optimizing a patient's physical and mental health before a lung transplant to improve recovery and outcomes after transplant. So, prehab programs include exercise, optimizing nutrition, and then psychological support as well. So, a lot of times, prehab is done in the Pulmonary Rehabilitation Center. And so, it will help your patients be in the best physical condition they can be in prior to transplant. So, as a community APP, encouraging your patients to attend pulmonary rehab prior to transplant is huge. I know when you have a patient waiting for lung transplant, breathing is hard. And so patients sometimes don't think that they can exercise or that it's not something that they can do. But if they can maintain their physical activity as much as they can and work to maintain their muscle mass, particularly prior to transplant, it will really benefit them in the long run. So, as a medical provider, encouraging your patients to continue to be as physically active as they can in spite of their disease will really stack the deck in their favor.
And Sarah, you had mentioned that too. At your center, only about 50% of the referred patients have been to rehab.
Yeah, I was gonna say that's like anecdotally from, talking to patients. We're here in Arizona, so we get teach night from within Arizona, different cities, but then also outside of Arizona. So it's always kind of surprising to me when I talk to patients had, they're going to maybe for a couple of years, but they've never heard of pulmonary rehab. They haven't, ever, been to one. So I cannot stress the importance enough of that pulmonary rehab, physical therapy, because the investment you put into your health, like your muscle health before transplant, is really going to kind of help you post transplant to heal.
Perfect. And, in addition to physical support with rehab, these patients require family support. And many transplant centers require two caregivers, and sometimes patients don't anticipate that. So, Elizabeth, can you talk a little bit about the importance of support and what that might look like for a potential lung transplant recipient?
Yeah, support is really important. It's not just having a caregiver that can be there with you, but someone who can really support and walk along the journey with you makes a huge difference. At our facility, we require patients to stay in town for 90 days after their transplant, and they have to be accompanied by a caregiver for the full 90 days. So this is a pretty big commitment. But then that commitment often doesn't end just at that 90-day mark. They continue to be a support and a caregiver when the patient returns home as well. Recovering from a lung transplant is a big proposition, and it can take a while to get to your new normal. There's a lot of education that happens post transplant on medications, food safety, nutrition, infection prevention and control, etc. And so the transplant recipient really needs a partner in this education, someone who can learn with them and help them help kind of remind them of the things that they've learned together and help them with their medications. I think that's a big thing, just like keeping all those medications straight, someone who can kind of help them organize that and set them on the right track.
Yeah. Sarah, has that been your experience as well?
Absolutely. Each center, they said it may be a little different, but we require two caregivers, the primary caregiver and a backup caregiver, because that role is so important. Yes, the primary caregiver is like the eyes and ears for you while you're at home recovering. They come to all the appointments, just as Alyssa was talking about. But I think another thing that kind of, open the door to a little bit is that even the primary caregiver needs support from one person. And it can be common where, I mean, hey, having a lung transplant is very stressful for that patient, but also for the patient, or the caregiver, like that primary caregiver. They always want to try and prevent caregiver burnout. It's a real thing, right? So that's why, we'll often say you need the primary goes to and a backup for that. But no, I cannot stress the importance enough of a caregiver. Transplant difficult, as we've been talking about so far, and you need another person to go through that journey with you.
Absolutely. And we require the same thing here at Vanderbilt. And 90 days after transplant, they must stay in the very close area, like within 10 minutes of us. But other centers require that they move their pre-transplant. So it's important to get to know and develop a relationship with your specific transplant center or centers to know what their rules are. And then as healthcare providers, Elizabeth, we all worry about infection and rejection. Can you talk a little bit about both of those and what should be looking for?
Yeah, patients are at their highest risk for infection in that immediate postoperative transplant period. So, that first year following transplant, we're really aggressive with any kind of infectious symptoms that they might get. Additionally, in general, lung transplant patients tend to be on higher doses of chronic immunosuppression versus other solid organ transplants, which obviously increases their risk of infection as well. Our lung transplant patients have their transplanted lungs kind of in constant contact with that environment, right? You can't really protect the lungs from breathing that air in. And so, in a healthy host, your lung acts as a filter for pollution and environmental organisms, et cetera. So, in an immunosuppressed patient, the lungs act as a filter, but it puts them at a higher risk for that infection. respiratory viruses like the rhinovirus that would normally just cause kind of an upper respiratory infection like symptoms can cause immune activation in a transplanted lungs, precipitating like an immune cascade resulting in either an acute rejection or a more chronic type of rejection called chronic lung allograft dysfunction or CLAD. So post transplant, I feel like it's a constant effort to continually balance our risk of rejection with our risk of immunosuppression. So we want to decrease our immunosuppression to just enough that they're not rejecting and allow the immune system to be as active as possible without it causing rejection in that lung. So that kind of constant balance of the two, finding that right combination, which can be individual to each patient.
Absolutely. Anything to add, Sarah?
No, she's hit all the high points I want to talk about.
Yeah, I will say that was a great summary. And I will say, when I first transitioned from general pulmonary to transplant, I had to be reminded that just because someone's white count was down or up, if they were on steroids, and
Mhm.
then, it didn't necessarily mean the same thing in a transplant patient. So, always call your transplant center, and they might not necessarily be febrile if they're very immunocompromised. So keeping in mind those types of things, with infection and even rejection. The most common signs of rejection, including a decreased FEV1 or just not feeling something's not quite right. Just to be hyper vigilant to those things. Um, Sarah, can you talk a little bit about dual transplant when you transplant multiple organs?
Yeah, so it's not all common in every lung transplant center. Some transplant centers do heart transplant and lung transplant. Some centers, like us right now, we don't have that ability. But yeah, you can have a dual transplant of a kidney and a lung, or heart and lung. So it's very dependable, or excuse me, very dependent on that transplant center's program. And of course, there's always within both organs you have to meet the specific requirements, right, for having transplant. But it is
Absolutely.
possible. But again, there's a lot of things you have to look into it for.
Absolutely. And then I don't know if it's been your experience, but it was mine that you just have to decide who the driver is. If it's heart, lung, if it's heart and liver, you have to figure out where the book is going to stop.
Yes.
Yes. So obviously, those types of transplant come with increased risk. But when it's just, I'll just say lung transplant in general, Elizabeth, I know there have been some advances, but what is the current mortality?
Yeah, so I just looked it up in preparation for this podcast so that we would have the most up-to-date information. And the 2024 one-year survival for lung transplant was between 85 and 89%, kind of depending on where you looked. The 3-year national average was around 74%. And then the last ISHLT median survival rate for lung transplant that they posted was from January 1992 to June 2017, and it was 6.7 years for adults overall. There was a little discrepancy in the survival rate between bilateral lung transplants, which have a median survival of 7.8 years, and a single lung transplant, which has a median survival rate of 4.8 years.
Wonderful. I don't know about you guys, we've all been doing this a while. When I first came into transplant, that 5-year survival was closer to 4 to 5 years. So I'm
Yeah.
happy to see the involvement. I'm also jealous of other transplant types like kidney, heart, and liver. They're all covered in skin. And lung, our immunosuppression level in general is higher. And we also are breathing 20 times a minute into an immunocompromised organ. So our rates of infection and rejection are, of course, higher. Um, so if you need to refer to someone, Sarah, how do you find out, where there's a lung transplant program in your state?
Well, the best place to look, I would say, because sometimes you live in a big state, you just didn't know you might have one right around the corner, is to go to the srtr.org website, it's the Scientific Registry of Transplant Recipients. It's a very easy to use website. You literally pick what organ you're looking to transplant. So you put lung and you enter the zip code, the city, and it can pull up, a certain number of transplant centers within a certain mile radius or whatnot. So that would be the first way to see which transplant center is near you. Also, if you ever have questions about like transplant, don't hesitate to call out to a transplant center. I'm more than happy to answer questions. I would rather have people have questions about referrals, maybe refer somebody a little too early than too late to then, the point where that patient is like, really, too sick to have surgery and have a really good outcome with transplant. But yeah, that would be the best way, the srtr.org website. And also just kind of connecting with your fellow peers, other physicians, pulmonologists, and PAs that you work with, to find out and ask around. Right? I think we've all kind of learned, you ask around, you don't know what you don't know until you ask. So I think everybody within, the pulmonary world is very happy to help each other out because we're all looking out for the benefit of our patients.
Yes, and you bring up some great points. I used to get very confused with the alphabet soup between SRTR, the registry, and UNOS, the United Network for Organ Sharing, that ensures that we allocate organs fairly. But just as you said, one of the reasons to be a member of APAP is community networking. And I have had other NPs and PAs call the transplant center, identify themselves as an NP or PA, and ask to have me call them back. And that's how I've gotten to know a lot of the pulmonary APPs in my area. So absolutely would not hesitate to do that. Okay, we're approaching the 20-minute mark and we promised to keep this short. So let's end with Elizabeth. If someone is a seasoned advanced practice provider in pulmonary, what is something about transplant you would want them to be sure and remember?
I think remembering that guidelines change all the time, so just staying up to date is really important. Always feel free to call the transplant center if you ever have any questions, and don't take them off any medications without checking with the transplant center first. There's quite a few common medication interactions with some of the transplant medications, tacrolimus and the antifungals that they're on. So if you take them off the antifungal, we really have to adjust that tacrolimus level. And so just kind of those types of things will be really important to just contact the transplant center if they have any questions.
Great. And Sarah, what if you're brand new and into pulmonary? What do you want to remember about transplant, lung transplant?
Well, always remember your patient. Are you keeping your patient up to guideline treatment for whatever their lung disease is? Are they maximizing on the treatment? I brought up already before the srtr.org website, the ISHLT guidelines as well. Those are those are a lot of information on the internet for both of those resources. And, of course, if you're brand new, which you don't know what you don't know, let, ask in your peers. But I think as long as you don't also forget about the health outside of that patient. I know Elizabeth we had already talked about pulmonary rehab. Don't forget about those things. Health screening, colonoscopies. I know as pulmonologists, that's not like what patients are usually coming for us, but, making sure that outside of their lung health, they are, having the appropriate care.
Yeah. Sarah, that's a great point because I think that's why APPs work well in transplant because we do keep up with health maintenance, which when you turn someone's immune system down becomes even more important. And also helping control their comorbidities that we make worse, the diabetes, the osteoporosis, those types of things. So I really do think that's why APPs fit so well in lung transplant. And with that, we will conclude our episode. This has been the Lung Transplant Committee of APAP. If you'd like to join our committee, we would love for you to. If you'll just email info@pulmapp.com, we'll be more than happy to welcome you to our committee. If you would like to claim CME for this podcast, we appreciate both Elizabeth and Sarah very much sharing their knowledge. Then the CME link will be in the notes in the podcast. And we appreciate you very much for your time. Thank you.